Good morning, doctors. I am Dr. Sesha, your study buddy for studying for MRCGP International AKT exam. Today is our 16th day of reading Oxford Handbook of General Practice, and I hope you have followed each and every day till now. And if you haven't, you can anytime go to the channel and start revising or reading the chapters from day one. So today we are at page number 376. Let's start. Patient with ostomies. Specialist stoma nurses are extremely useful source of advice and help if in doubt about the correct stoma appliances and accessories to supply, or a patient has a problem with a stoma. Wherever possible, liaise with your own specialist stoma nurse. First iatrogenic stoma was constructed in France in 1776 for an obstructing rectal cancer. Stomas, from the Greek meaning mouth, may be temporary or permanent. Stoma retraction can lead to leakage and severe skin problems. Most common reason for reoperation. Refer for a specialist advice. Prolapse, seen most frequently with loop colostomy. If persist and disrupts the pouching, refer for consideration of revision. Peristomal hernia, common complication. Symptomatic cases require referral for repair. Stenosis, narrowing of the stoma may result in difficulty or pain in passing the stool and or obstruction. If problematic, refer for revision. Skin complication, skin irritation can be due to leakage onto the skin, allergic reaction to the adhesive material in a skin barrier, fungal infection, or inadequate hygiene. Prevention of skin complications. Advise the patients to clean and rinse and pat dry the skin between the pouch changes. Avoid using an oily soap which can leave a film that interferes with proper adhesion of the skin barrier. Ensure the pouch system fits. Treat any infection from the with oral antibiotics and oral or topical antifungals. Apply a skin barrier cream. If the skin is uneven due to scarring, fill the irregularities with stoma paste to give a better fit. Consider the use of convex discs or stoma belts. Refer to a specialist stoma nurse for advice. Diet. Avoid the foods that cause intestinal upset or diarrhea. For descending and sigmoid colostomy, avoid foods that cause constipation. If constipation does occur, increase the fluid intake and or dietary fiber. Certain foods like beans, cucumbers, carbonated drinks can cause gas, along with certain habits such as talking or swallowing air while eating, using a straw, breathing through the mouth, and chewing gum. The daily portion of applesauce, cranberry juice, yogurt, and buttermilk can help control odor. If odor is strong and persistent, consider use of charcoal filters or pouch deodorizers. Seek advice from a specialist stoma nurse. Three main types of stoma: colostomy, ileostomy, and urostomy. So colostomy, age more than 50 years, output depends on the site. It's a transverse colostomy, soft stool; descending or sigmoid colostomy, firm stool. Reasons for colostomy can be carcinoma, diverticular disease, trauma, radiation enteritis, bowel ischemia, Hirschsprung's disease, congenital abnormalities, obstruction, Conn's disease, fecal incontinence. Ileostomy. Out, peak age is 10 to 50 years. Output of a soft and fluid stool. Reasons for ileostomy are ulcerative colitis, Conn's disease, familial polyposis coli, obstruction, radiation enteritis, trauma, bowel ischemia, meconium ileus, and carcinoma. Urostomy. Age mostly more than 50 years. Output is urine. Continent procedure using bowels to fashion a bladder, which is then drained with a catheter through the stoma, are becoming common. Reasons for urostomy: carcinoma, urinary incontinence, fistulas, and spinal column disorders. Drugs. Enteric coated and modified release preparations are unsuitable for people with bowel stomas, particularly for patients with ileostomy. Psychosocial problems. Self-help groups provide information, tips on lifestyle and stoma care. Specialist stoma nurses can provide support and counseling. Activities. Advise patients to avoid rough contact sports and heavy lifting as these might cause herniation around the stoma. Patients with stomas may swim. Water will not enter a stoma due to peristalsis, so stomas do not need to be covered when bathing. A body belt available on FP10 to hold the stoma bag in place against the body may stop rustling and or leakage for those doing aerobic exercise. Seek advice from a specialist stoma nurse. Travel. Advise patients to pack sufficient supplies of the stoma products and carry supplies with them in case the bag is misplaced. Avoid storing the supplies in a very hot environment as heat may damage the pouches. Page number 378, we are in chronic diarrhea and malabsorption. Chronic diarrhea, diarrhea persisting more than 4 weeks. Patient with perceptions of diarrhea may vary widely. Patient's perception of diarrhea may vary widely. Clarify what is meant. So when the patient is complaining of diarrhea, ask him what is the meaning, what he is meaning by it. Chronic diarrhea affects 4 to 5% of adults in UK. There are many causes, table 12.11, and all the patients require investigations. Careful history is vital. Symptoms suggestive of an organic diseases, history of less than 3 months duration, mainly nocturnal or continuous as opposed to intermittent diarrhea, significant weight loss, liquid stools with blood or mucus. Symptoms suggestive of malabsorption. These are the symptoms suggestive of organic disease, and these are of malabsorption. When pale or offensive stool, steatorrhea, excess fat in the feces, the stool is pale colored and foul smelling and floats, difficult to flush. Examination and investigation. Full examination. Look for signs of systemic disease and examine the abdomen or pelvis thoroughly. Check for blood, FBCs, ESR, calcium, LFTs, hematinics, TFTs, celiac serology, CA125 in women. Refer for ultrasound scan of the abdomen or pelvis if any of these are raised. If CA125 is raised. Stool. Microscopy, culture sensitivity plus fecal calprotectin useful in primary care for distinction between IBS and inflammatory bowel disease if the patient is less than 40 years. Management. If obvious identifiable causes present, the GI infection, constipation, drug side effect, treat and review. Refer to gastroenterology if treatment fails. If the symptoms are suggestive of functional bowel disease and age is less than 45 years with normal investigations, irritable bowel syndrome is likely. Reassure, offer advice and review as necessary. Refer for gastroenterology if atypical symptoms appear or the patient is unhappy with the diagnosis. Otherwise, refer to gastroenterology for assessment. Speed for referral depends on the age and severity of the symptoms. So, refer urgently, that is to be seen within 2 weeks to a team specializing in colorectal cancer if any age plus anal, rectal or abdominal mass is present. If any age plus rectal bleeding or unexplained abdominal pain, change in bowel habit, weight loss or iron deficiency anemia is present. If age is more than 40 years and there is an unexplained weight loss or abdominal pain, if age is more than 50 years and there is unexplained rectal bleeding, if age is more than 60 years and iron deficiency anemia or persistent change in bowel habit or fecal occult blood is positive, a pelvic mass outside the bowel warrants urgent referral to urologist or a gynecologist. For a direct access CT or ultrasound, if CT is not available, if you have to refer to direct access CT or ultrasound if age is more than 60 years plus weight loss and more than one of the following symptoms are present like diarrhea, there is back pain, there is abdominal pain, there is nausea, vomiting, constipation and new onset diabetes. So in these cases you are supposed to refer them directly for a CT scan or ultrasound scan. If a patient is more than 60 years and he has weight loss and also he has diarrhea, back pain, abdominal pain, nausea, vomiting, constipation and new onset diabetes. Causes of chronic diarrhea. Causes are colonic cancer, ulcerative colitis, Crohn's disease, constipation with overflow, diarrhea. Endocrine causes are diabetes, autonomic neuropathy, hyperthyroidism, hypoparathyroidism, Addison's disease, hormone secreting tumors, example carcinoid. Small bowel causes are Crohn's disease, celiac disease, other enteropathies like Whipple's disease, bile acid malabsorption, ischemia, enzyme deficiencies, example lactase deficiency, radiation damage, bacterial overgrowth, lymphoma, infections, giardiasis, cryptosporidium, intractable irritable bowel syndrome. Pancreatic causes are pancreatic cancer and chronic pancreatitis, cystic fibrosis. Others are ovarian cancer, bowel resection, bile salt malabsorption, intestinal fistula, drugs, alcohol, autonomic neuropathy, factitious diarrhea. Malabsorption. Presence with chronic diarrhea, weight loss and steatorrhea, vitamin or iron deficiencies and or edema due to protein deficiency. Refer for gastroenterology for investigation or treatment of the cause. Usual causes are celiac disease, Crohn's disease, chronic pancreatitis. So these are the usual causes of malabsorption. Rarer causes of malabsorption are cystic fibrosis, pancreatic cancer, Whipple's disease, biliary insufficiency, bacterial overgrowth, chronic infection like giardiasis and tropical sprue following gastric surgery. So these are the infective causes of malabsorption, giardiasis and tropical sprue. And following gastric surgery, Whipple's disease, a cause of malabsorption which usually occurs in males more than 50 years. And the other features are arthralgia, pigmentation and weight loss, lymphadenopathy plus cerebellar or cardiac signs. Arthralgia, Whipple's disease, arthralgia, pigmentation, weight loss, lymphadenopathy, cerebellar or cardiac signs. Causes are Triphonema Whipple. Refer for gastroenterology referral. Assessment. Jejunal biopsy is characteristic and treatment is long-term broad-spectrum antibiotics. Malabsorption in children, page 866, we will read that later. Factitious diarrhea. Responsible for 4% of referrals to gastroenterology department, 20% of tertiary referrals due to laxative abuse or adding of water or urine to stool samples. Difficult to spot and have high index of suspicion, especially if patient with a history of eating disorder or somatization. Page number 380, fecal incontinence. Fecal incontinence affects 2% of all ages, causing great personal disability. It is common reason for carers to request placement in a nursing home. Okay. Causes: age and frailty, constipation, overflow incontinence, childbirth, colonic resection or anal surgery, rectal prolapse or hemorrhoids, loose stools or diarrhea from any cause like inflammatory bowel disease after radiotherapy, systemic sclerosis, neurological disorders, cognitive deficit, congenital disorders, example anal atresia, Hirschsprung's disease, emotional problems, encoparesis in children. History aimed at establishing the underlying cause of incontinence, may be more than one, and other factors that might be attributing to it. Ask about the onset and nature of symptoms. Always consider fecal incontinence when patients present with anal soreness or itching. Bowel habit including the timing and frequency of incontinence. Difficulties with toileting are and help available. Other medical conditions, medications, diet or social circumstances. Examination. General and rectal examination to detect the abnormalities of anal tone and local anal pathology. Example, rectal prolapse, constipation causing overflow incontinence. Further examination depends on the age group and history. Example, cognitive assessment if suspected, cognitive deficit, neurological examination if there is reduction in anal tone. Okay. Persistent change in bowel habit to lose a stool may be a sign of GI malignancy. Primary care management. Treatment of cause. Clear any constipation or fecal loading. Page number 350. Use rectal preparations initially to clear the fecal load. If unsuccessful, rectal preparations are inappropriate, then switch to oral laxative. Take steps to prevent recurrence. Add a fiber to the diet, that is, increase the fluid intake, consider regular laxatives, treat other reversible causes, example, infective diarrhea or ulcerative colitis, consider alternatives to any contributing medicines, example, tranquilizers. General measures which can cause for where the cause cannot be treated. Advise fluid intake at least 1 to 1.5 liters per day. Encourage bowel emptying after a meal. Advise patients to assume a seated or squatted position and not to strain. Ensure that the toilet facilities are private, accessible and safe. Refer to the OT assessment if needed. Manipulate the diet to promote optimal stool consistency and a predictable bowel emptying. Food or fluid diary may be helpful. Only change one food at a time. Consider referral to a dietitian. If stool must be in the rectum at a set time, example when a carer is there, manipulate the bowel action with PR or PO laxatives and or loperamide. If loose stools, then consider treatment with loperamide, cofenotrope or codeine phosphate (PRN) or continuously. When using loperamide, introduce at very low dose, consider syrup for doses less than 2 milligrams and increase the dose until desired stool consistency is reached. Dose and or frequency can be adjusted in, increased or reduced in response to stool consistency and lifestyle. Do not use if hard stools, undiagnosed diarrhea, or flare up of ulcerative colitis is there. Review regularly. If there is no improvement with simple strategies, consider referral for specialist care. Patients with fecal incontinence from enteral feeding. Discuss the patient's dietitian. Modify the type and timing of feeds may help. Patients with spinal injury or disease. Bowel function is a reflex action which we learn to override as a child, as children. If the lesion is above the level of this reflex pathway, T12 for bowel function, then automatic emptying will still occur when the bladder or bowel is full, although there is no control. If the lesion is below this level, there is no emptying reflex. So bowel care programs reflect this. Useful leaflets are available for spine injuries association. Referral. Consider if symptoms are not controlled to refer to a continence advisor for advice on skin care and hygiene and supplies of incontinence pads, pelvic floor muscle training and bowel retraining, biofeedback, electrical stimulation or rectal irrigation may be useful. Devices or anal plugs or fecal collectors can help in some situations. To surgeon, if you need to refer to a surgeon for splinter repair, if significant splinter defect is there, for consideration of implanted sacral nerve stimulation device, for appendicostomy, continent colonic conduit, for anterogate irrigation in patients with colonic motility disorders, for stoma formation as a last resort. Okay, these are the surgical options and we have to refer to a surgeon. One is for splinter repair, second is for consideration of implanted sacral nerve stimulation device, and third is for appendicostomy or continent colonic conduit, for anterogate irrigation in patients with colonic motility disorders, and for stoma formation as a last resort. To old age psychiatry, if cognitive deficit and incontinence is present. To pediatrics, if encoparesis due to chronic constipation, or child psychiatry if encoparesis due to emotional distress. Encoparesis in children, 893. Celiac disease. Celiac disease is a common disorder. UK prevalence is 0.5 to 1%. Females to male ratio is 3:1. Although only a minority have recognized disease, gluten sensitivity results in inflammation of the bowel and malabsorption. Peak incidence in adults is in the 5th decade, in children at 4 years. So in adults, the peak incidence is 5th decade, but in children, it is 4 years of age. Associated with HLA DQ2 and DQ8, first degree relatives have a 1 in 10 chance of being affected. See the table 12.2. Investigations for celiac disease, serological testing, IgA anti-tissue transglutaminase antibodies. IgA anti-tissue transglutaminase anti-TTG or anti-endomycin antibodies are the diagnostic test if persistent unexplained GI symptoms, flattering growth, prolonged fatigue, unexplained weight loss, severe or persistent mouth ulcers, unexplained iron, B12 or folate deficiency, type 1 diabetes or autoimmune thyroid disease is present. Thyroid disease at diagnosis, irritable bowel syndrome. So in case of type 1 or autoimmune diabetes, autoimmune thyroid disease, at the diagnosis itself, we have to check for celiac disease. Irritable bowel syndrome, first degree relative with a celiac disease. Test only if eaten more than one meal per day containing gluten for more than 6 weeks. Other tests also consider FBC, ESR, CRP, vitamin B12 levels, folate levels, iron levels, ferritin levels, LFTs, calcium, thyroid function test, stool sample for microscopy, culture sensitivity if diarrhea is present. IgA deficiency is uh, more, there is a increased incidence of IgA deficiency 6 times in people with celiac disease. So if IgA is deficient, IgA TTA, tissue transglutaminase or endomycin antibodies may give a false negative result. If clinical suspicion, IgA tissue transglutaminase or EMA is negative, check for serum IgA levels. And if they are deficient, request for IgG, tissue transglutaminase or anti-endomycin antibodies. See, initially we are checking for IgA levels. So in case serum it has given a false negative result and still you have a clinical suspicion of celiac disease, then you will check with serum IgA levels. If serum IgA levels are deficient, then request an IgG, TTG, EMA antibody testing. Initial management. Refer for specialist review if there is a positive serology. Duodenal biopsy shows villus atrophy is diagnostic. Strong clinical suspicion. So when there is a positive serology, you have to refer for a duodenal biopsy. Strong clinical suspicion of celiac disease but negative serology. Unwilling to reintroduce gluten to diet to enable strong serological testing. Gluten-free diet is a cornerstone of management of celiac disease, should be followed lifelong. Avoid proteins derived from wheat, rye or barley. Avoidance of oats is controversial. Avoidance of oats is controversial, but you have to avoid proteins derived from wheat, rye or barley. Refer for dietitian for specialist advice. Celiac UK provides directory of approved products as well as recipes for those on gluten-free diets. Prescription of gluten-free foods. Prescribe adequate gluten-free foods. Marking prescriptions as ACBS. Add deficient nutrients, example iron, folic acid and calcium until established on a gluten-free diet. Failure to respond to diet. Most commonly due to continued gluten ingestion, intentional or inadvertent, refer to dietitian. So the failure to respond to diet is because of they are not compliant on gluten-free diet. So if in that case, refer to a dietitian. If the symptoms recur after a period of remission, refer to a specialist review. Pneumococcal vaccination. Pneumococcal infection is more common secondary to hyposplenism in celiac disease. Advise vaccination of pneumococcus. Follow-up. Follow-up is every 12 months by GP. Routine checks include symptoms, weight, diet. Consider the blood test, hemoglobin, B12, folate, iron, albumin, calcium, TTG, EMA antibodies, comorbidities and need for specialist follow-up. Long-term complications. Almost eliminated by a strict diet, osteoporosis. Consider DEXA scan at diagnosis after 3 years on gluten-free diet if abnormal baseline DEXA, and at menopause for females aged 50 females at menopause for females aged 55 and for males, or if fragility fracture is present. So, in case of celiac patient, you have to consider a DEXA scan at diagnosis. And if there is an abnormal baseline DEXA, then after every 3 years of on a gluten-free diet. And also you have to consider DEXA scan at menopause for females, and if patient is male more than 55 years of age, you have to consider for DEXA, or if there is a fragility fracture. Malignancy. Lymphoma or carcinoma of the small intestine is common, rare. If suspected, is rare. If suspected, refer urgently for specialist review. Presentation of celiac disease. Symptoms and signs. Symptoms and signs of celiac disease: chronic intermittent diarrhea, 50% patients; failure to thrive or flattering growth in children. In children, celiac presents with failure to thrive. Recurrent abdominal pain or cramping or bloating. Other persistent unexplained GI symptoms. Example, nausea and vomiting. Sudden or unexpected weight loss. Unexplained anemia, iron deficiency or other. Genetic predisposition of celiac disease. First degree relative. If positive, then there is predisposition. Parent, sibling or child. Down syndrome or Turner syndrome is also one of the genetic causes. Associated conditions with celiac disease. So there are a number of associated conditions with celiac disease. GI conditions are GI, dental enamel defects, mouth ulcers, irritable bowel syndrome, microscopic colitis, persistent unexplained constipation, unexplained or persistent increase in liver enzymes usually normalize in less than 6 months on gluten-free diet, autoimmune liver disease. Musculoskeletal problems with celiac disease are decrease in bone mineral density, low trauma fracture, metabolic bone diseases like rickets, osteomalacia, Sjogren's syndrome, and sarcoidosis. Endocrine associations: type 1 diabetes, autoimmune thyroid disease, Addison's disease, amenorrhea. So endocrine associations are type 1 diabetes, autoimmune thyroid disease, Addison's disease, and amenorrhea. Others are, and amenorrhea is a presentation, whereas the rest of the three are associations because of autoimmunity. These are all a spectrum of autoimmune diseases, celiac disease also. So this is so type 1 diabetes, autoimmune thyroid disease, and Addison's disease are also autoimmune diseases associated with celiac. Amenorrhea is a symptom. Others are unexplained alopecia, dermatitis herpetiformis, depression or bipolar disorder, polyneuropathy, epilepsy, autoimmune myocarditis, chronic thrombocytopenic, chronic TTP, lymphoma, thrombotic thrombocytopenic purpura, autoimmune myocarditis, lymphoma, recurrent miscarriages, unexplained subfertility. Guide to the amount of gluten-free products to prescribe. Monthly for patients with celiac disease. If the patient is 1 to 3 years, the child age 1 to 3 years, units is 10 units. Male age, okay, this is okay, fine. So child age 1 to 3 years is 10 units, 4 to 6 years is 11 units, 7 to 10 years is 13 units, and 11 to 14 years is 15 units. 15 to 18 years is 18 units. 19 to 59 years is 18 units. 16 to 74 years 16 units. 75 plus is 14 units. Female age 19 to 74 is 14 units. 75 years plus is 12 units. Breastfeeding. Adults add 4 units. Third trimester of pregnancy add 1 unit. High activity level. Male or female add 4 units. So 400 grams of bread or rolls or bagut is 1 unit. 500 grams of bread or flour is 2 units. And 200 grams of sweet savory biscuits, crackers or crisp bread is 1 unit. And 250 grams of pasta is 1 unit. 2 pizza bases is 1 unit. So these are prescribed on the NHS in patients with celiac disease. Inflammatory bowel disease. Ulcerative colitis and Crohn's disease are collectively termed inflammatory bowel disease. Both are chronic, relapsing, remitting diseases characterized by acute and non-infectious inflammation of the gut. In ulcerative colitis, inflammation is limited to the colorectal mucosa. The extent varies from disease limited to the rectum, proctocolitis, to disease affecting the whole colon or pancolitis. In Crohn's, any part of the gut from the mouth to the anus can be affected, with normal bowel in between the areas called skip lesions. Causes unknown. Both the diseases are thought to result from environmental trigger factors or genetically susceptible individuals. Factors implicated, none is proven, include smoking. Smoking is protective in ulcerative colitis. 95% are non-smokers or ex-smokers, but causative factor in Crohn's disease. Two-thirds are smokers, and smoking cessation halves the relapse rate. Gut flora or other infections, example Mycobacterium paratuberculosis infection. Food constituents. Features, table 12.15. Differential diagnosis. Irritable bowel syndrome, celiac disease, anal fissure, any causes of chronic diarrhea. IBS, celiac disease, anal fissure, because there will be fissures and fistulas also in Crohn's. Gut infection, giardiasis, diverticulitis, colonic tumor, food sensitive colitis, infants, pseudomembranous colitis, ischemic colitis, microscopic colitis. Suspected diagnosis. 50% of severe attacks of ulcerative colitis are the first attacks in patients who do not have a prior diagnosis. If bloody diarrhea plus fever plus more than 37.5 or tachycardia more than 90 beats per minute, admit as an acute emergency. If persistent unexplained diarrhea long lasting more than 4 weeks and or persistent abdominal pain, refer for further investigation to exclude a GI malignancy and establish the diagnosis. Assessing the severity of ulcerative colitis. Symptoms: mild, less than 4 liquid stools per day, little or no rectal bleeding, signs of no signs of systemic disturbance. Manage in primary care. So in case of mild ulcerative colitis, less than 4 stools, no bleeding, no signs of systemic disturbance. Moderate, 4 to 6 stools, moderate rectal bleeding, some signs of systemic disturbance, mild disease that does not respond to treatment. All these 4 are moderate. Consider for admission, contact a specialist team for management advice. Severe cases, more than 6 liquid stools per day, severe rectal bleeding, any systemic disturbance, that is either high pulse rate more than 90, pyrexia, ESR is high, WCC is high, hemoglobin is low, that is less than 10 grams, signs of malnutrition, albumin less than 35 grams per deciliter, weight loss more than 10%. Admit as an emergency. Features of inflammatory bowel disease and ulcerative colitis. So, ulcerative colitis and Crohn's disease. Ulcerative colitis. Incidence 10 to 20 per 1 lakh. Prevalence 100 to 200 per 1 lakh. Peak age, gender, it's all ages. It's not specific for age or gender. Risk factor: smoking is protective in ulcerative colitis. GI symptoms: diarrhea plus blood or mucus. Stool may be solid if rectal disease only. Diarrhea plus blood or mucus. Stool may be solid if rectal disease only. Fecal urgency or incontinence, tenesmus, lower abdominal pain are the symptoms, GI symptoms of ulcerative colitis. Tiredness or malaise are systemic symptoms. Weight loss, failure to grow or thrive in children, and fever. Associated conditions with ulcerative colitis are joint disease, arthritis, sacroiliitis, ankylosing spondylitis. As such, these are common for both ulcerative colitis and Crohn's disease. So we'll just see what are the differences first and then go back to the common managements. Crohn's disease is 5 to 10 in 1 lakh, so it is less common, and prevalence is 50 to 100. This is also less common. And peak age, there's a peak age for Crohn's disease, that is 40 to 60 years. Okay, 85% are less than 60 years of age. Gender, there is no gender variation in Crohn's disease. Males and females are equally affected. Smoking is a risk factor for Crohn's disease. So a person with a Crohn's disease, you have to advise smoking cessation. GI symptoms, diarrhea plus blood or mucus. Malabsorption is there in Crohn's disease. Abdominal pain, that is crampy. Mouth ulcers, bowel obstruction due to strictures, fistulae, often perianal fistulae. Abscesses, perianal or intra-abdominal abscesses are there. So both of them have blood and mucus. Diarrhea, which may or may not have blood and mucus, but in case of ulcerative colitis, diarrhea is always associated with blood and mucus. Fecal urgency, incontinence, and tenesmus are symptoms of ulcerative colitis because of rectal involvement. So, systemic symptoms are same for both ulcerative colitis and Crohn's disease. We have read them. Associated conditions for both ulcerative colitis and Crohn's disease. Joint disease are arthritis, sacroiliitis, ankylosing spondylitis. Eye diseases like iritis or uveitis. Skin changes. Erythema nodosum, pyoderma granulosum. Ulcerative colitis more is common. Pyoderma granulosum more common in ulcerative colitis than Crohn's disease. Liver disease. Autoimmune hepatitis, ulcerative colitis, more common in ulcerative colitis, gallstones, more common in Crohn's disease. Sclerosing cholangitis, ulcerative colitis is more common in ulcerative colitis than Crohn's disease. Miscellaneous, thromboembolism, osteoporosis, Crohn's disease, amyloidosis as in Crohn's disease. Examination, abdominal plus rectal examination. Abdominal tenderness, anal and perianal lesions, pendulous skin tags, abscesses, fistulae or mass in the right iliac fossa are characteristic of Crohn's disease. General examination, clubbing, aphthous ulcers in the mouth, Crohn's aphthous ulcers, signs of weight loss, anemia or hypoproteinemia. Investigations, blood, FBC, anemia, full blood count, there is anemia and raised white cell count. ESR is increased when the disease is active. EGFR, LFTs include serum albumin. In severe ulcerative colitis, the C-reactive protein is more than 45 grams per deciliter. After 3 steroid treatments indicate high risk for colectomy. Stool microscopy and culture sensitivity including Clostridium difficult to exclude infection. AXR, considered to clarify the extent of disease, exclude toxic megacolon. This is abdominal X-ray. To clarify the extent of disease, exclude toxic megacolon, transverse colon diameter more than 5 centimeters is classic of toxic megacolon, or bowel obstruction or identify any proximal constipation. Proctoscopy, inflammation and shallow ulceration extending proximally from the anal margin suggests ulcerative colitis. Ulcerative colitis and Crohn's disease are rare in childhood. Presentation is variable and can be with non-specific features. Failure to thrive, GI symptoms, malabsorption, bloody diarrhea, acute abdomen, or complications, example arthropathy or iritis. If suspected, refer for confirmation of diagnosis and specialist management. And as we have read, specialist management. 386. Management of ulcerative colitis. Active disease. When there is an active disease. Mesalazine 2 to 4 grams daily. Topical ASA derivative are useful adjunct if troublesome rectal symptoms are present. Add steroids, prednisolone 40 milligrams ODPO or plus rectal preparation if prompt response is needed or mesalazine is unsuccessful. Review frequently and decrease the dose over 8-week period. Rapid withdrawal increases the risk of relapse. Azathioprine is added if the patient is having recurrent attacks despite mesalazine maintenance. Frequent steroids, more than 2 courses per year. Disease relapse as dose of steroid is decreased or relapse less than 6 weeks after stopping the steroids requires regular supervision. So in such cases, we have to add azathioprine. When he is having recurrent attacks, he is on mesalazine maintenance and he is having recurrent attacks requiring frequent steroids, more than 2 courses of for the past year, and the disease relapses as soon as the dose of steroid is decreased because you can't continuously give steroid long term, right? So you have to decrease the dose of steroid at some point, and whenever they are decreasing dose, there is a relapse of disease. At that time, as a steroid sparing medication, you will add azathioprine or relapse within 6 weeks of stopping the steroids. Regular requires regular supervision. Uh, Cyclosporin, infliximab, anti-TNF antibodies. Consultant supervised may be effective as an acute therapy for severe steroid refractory disease. Admit acutely if severe abdominal pain, especially if associated with tenderness, severe diarrhea more than 8 per day plus or minus bleeding, dramatic weight loss, fever more than 37.5, tachycardia more than 90, or other signs of systemic diseases present. Maintenance treatment. Follow-up in secondary care is routine. Most patients require lifelong therapy. Mainstays of treatment are 5-ASA derivatives. Example, mesalazine 1 to 2 grams per day or basilazide 2 to 2.5 grams per day. Use a rectal formulation. Example, mesalazine 1 gram per day PR if disease is confined to the rectum or descending colon. Long-term treatment decreases the risk of colonic cancer by 75%. 10% are intolerant to 5-ASA derivatives. Alternative is azathioprine. See earlier topic. Treat proximal constipation with stool bulking laxatives or laxatives, stool bulking agents or laxative. NSAIDs can precipitate relapse, so avoid in case of ulcerative colitis and Crohn's disease. Surgery. Last resort, but should not be delayed if severe colitis and failing to respond to medical therapy. So NSAIDs can precipitate a relapse in ulcerative colitis. Surgery is a last resort but should not be delayed if severe colitis and failing to respond to medical therapy. 20 to 30% of patients with pancolitis require colectomy. 1 in 3 develop pouchitis, non-specific inflammation of the ileal reservoir within 5 years of surgery. Prognosis. Prognosis at any time 50% are asymptomatic, 30% have mild symptoms, 20% of moderate or severe symptoms, less than 5% are free from relapse after 10 years. Relapses usually affect the same part of the colon. Complications table 12.7. Management of Crohn's disease. Active ileal or colonic disease. Treat with mesalazine 4 grams daily, less effective than ulcerative colitis. Add steroids, prednisolone 40 milligrams OD or budesonide 9 milligrams daily if unresponsive to mesalazine. Review frequently and decrease the dose over 8 weeks. Rapid withdrawal increases the relapse. Steroids are associated with increased risk of severe sepsis and mortality in Crohn's disease, so alternatives to steroid therapy are increasingly sought, and steroid maintenance for more than 3 months should always be avoided. Elemental or polymeric diets for 4 to 6 weeks can be useful adjunct or alternative to steroid treatment. Take consultant advice. Okay. Other treatments, consultant supervision including metronidazole. Under consultant supervision include metronidazole, azathioprine, anti-tumor necrosis factor drugs like infliximab and adalimumab. Surgery is an option if medical treatment has failed. 50% need surgery in less than 10 years after onset. Surgery is not curative and 50% will require a further operation at a later stage. After the ileal resection, check vitamin B12 levels annually. Admit acutely in case of Crohn's disease if severe abdominal pain is present, especially if associated with tenderness. Severe diarrhea is present more than 8 per day plus bleeding. Dramatic weight loss, bowel obstruction, fever or the other signs of systemic disease. So only bowel obstruction is a separate point, but otherwise rest of the 4 also apply for ulcerative colitis. For disease elsewhere, take a specialist advice. Maintenance treatment. Follow-up in secondary care is routine. Treatment is aimed at decreasing the impact of the disease. Mesalazine has limited benefit. It is effective at doses less than 2 grams, ineffective at doses less than 2 grams per day. Other agents also include azathioprine, mercaptopurine, methotrexate, infliximab, and adalimumab. All require consultant supervision. Treat diarrhea symptomatically with codeine phosphate or loperamide unless it is due to active colonic disease. Cholestyramine 4 grams 1 to 3 times a day, decreases the diarrhea due to terminal ileal disease or resection. NSAIDs can precipitate relapse, so avoid. Prognosis: 75% are back to work after the first year, but 50% remain unstable, unable to work long term. Complications: stable 12.6. Complications of inflammatory bowel disease, ulcerative colitis and Crohn's disease. Toxic megacolon, colon distance and may perforate. Ulcerative colitis complications are toxic megacolon. Colonic cancer increases the risk if the disease is more than 8 years. On, onset in childhood or adolescence, age more than 45 years. Adolescents age more than 45 years, family history of colon cancer, extensive colitis, sclerosing cholangitis, prevention for colonic cancer, screening with colonoscopy. Frequency depends on the severity of disease and duration of symptoms. Sclerosing cholangitis, fibrosis and stricture of the intra and extrahepatic bile ducts, presents with obstructive jaundice. About complications of Crohn's disease: intra-abdominal abscess, intestinal stricture, common, may require surgery. Toxic megacolon is rare, more common with ulcerative colitis. Bowel obstruction, fistula formation, perianal disease, malignancies, large and small bowel cancers, 5% 10 years after diagnosis, and there is osteoporosis associated with Crohn's disease. Psychological effects: chronic lifelong conditions which have major impact on work and domestic life, so self-help groups can be useful. So, the last topic for today is irritable bowel syndrome. Irritable bowel syndrome is a chronic, more than 6 months relapsing and remitting condition, unknown cause, symptoms including abdominal pain or discomfort, bloating, and change in bowel habit. Diagnosis is clinical, therefore no confirmatory test is required. Extremely common, lifetime prevalence is more than 20%, although more than 50% never consult a GP. Females more than males, 2.5 to 1. Symptoms can appear at any age. Diagnosis of IBS: abdominal pain or discomfort that is relieved by defecation, associated with altered bowel frequency or stool form, and two or more of the following: altered stool passage, straining, urgency, incomplete evacuation, abdominal bloating, females more than males, distension, tension, or hardness. Symptoms made worse by eating, passage of mucus. So, other commonly associated symptoms include lethargy, nausea, backache, and bladder symptoms. So, pain, abdominal pain or discomfort which is relieved by defecation is characteristic of IBS. Differential diagnosis: colonic carcinoma, celiac disease, inflammatory bowel disease, Crohn's disease or ulcerative colitis, pelvic inflammatory disease, endometriosis, GI infection, and thyrotoxicosis. All of this can present in a similar way. Investigations: a diagnosis of exclusion. How far to investigate is a clinical judgment, weighing the risk of investigation against the possibility of serious disease. Judgment is based on the age of the patient, family history, length of history, and symptom cluster. Patient less than 40 years, you only check the FBCs, fasting blood sugars, CRP, ESR, antibody testing to exclude celiac disease. So, if a young patient, then check the FBCs if there is any anemia, B12 deficiency, CRP if it is raised, ESR if it is raised, antibody testing to exclude TTAG and EMA. If patient is more than 40 years, colonic cancer must be excluded for any patient with persistent unexplained change in bowel habit, particularly towards the looser stools. Other investigations to consider are fecal calprotectin stool test plus or minus referral for colonoscopy to exclude inflammatory bowel disease as per local guidelines. Thyroid function test if other symptoms, signs of thyroid disease are present. Stool samples to exclude GI infection if diarrhea is present. Endocervical swabs for chlamydia. Laparoscopy to exclude endometriosis. So you have to rule out all the differential diagnoses and then come to a diagnosis of inflammatory irritable bowel syndrome. Referral to routine gastroenterology or general surgery. Passing blood, except if from an anal fissure or hemorrhoids, is an urgent referral. Abdominal, rectal, pelvic mass is an urgent referral. Unintentional unexplained weight loss is urgent or soon. Positive fecal calprotectin, inflammatory markers and or anemia is an urgent or soon referral. More than 40 years with new symptoms, urgent referral. If more than 60 years, soon or routine referral. Change in symptoms, especially if more than 40 years, urgent referral. If more than 60 years, soon or routine referral. Atypical features, that is, these are are not listed above, urgent, soon or routine. So change in bowel habits, usually wherever there is age is more, we tend to refer them urgently than when age is less. But in the case of this gastroenterology referrals, if age is more, change in bowel habits and new symptoms are there, and age is more than is soon or routine referral, because it's so common. The change in bowel habits are so common in higher age, but in younger age it is not so common. So they have to be referred urgently because of more sinister diagnosis. Family history of bowel or ovarian cancer is there, routine referral. Patient is unhappy to accept a diagnosis of IBS despite explanation, routine referral. Treatment. Reassure. Information leaflets are helpful. Encourage lifestyle measures, reduction of stress, leisure time, and regular physical exercise. Diet. Encourage patients to have regular meals and take time to eat. Avoid missing meals or leaving long gaps between eating. Drink less than 8 cups of fluid per day, especially water. Restrict tea, coffee to 3 cups per day. Decrease the intake of alcohol and fizzy drinks. Decrease the intake of high fiber foods, whole wheat, whole meal, high fiber, flour, breads, cereals, high in bran, whole grains such as brown rice. Decrease the intake of resistant starch found in processed or recooked foods. Limit fresh food to 380 grams portions per day. For so everywhere we are asking to eat more of these fiber containing foods, except in irritable bowel syndrome where we are asking them to limit these portions. For diarrhea, avoid sorbitol as an artificial sweetener. For wind and bloating, consider increase intake of oats, oat-based breakfast, cereal or porridge, and linseeds, less than 1 tablespoon per day. Up to 50% may be helped by exclusion of certain foods. Diaries may help to identify foods that provoke symptoms. Example, dairy products, citrus fruits, caffeine, alcohol, tomatoes, gluten, eggs. Refer to a dietitian. Specific measures. Fiber or bulking agents. Constipation predominant IBS, bran can make some patients worse. Oats and Isabella husk are better tolerated. Laxatives are an alternative, but avoid use of lactulose. So in case of constipation predominant IBS, you are not using lactulose. Antispasmodics. Example, mebivarin, peppermint oil, limited effectiveness. If no response in few days, switch to another. Different agents suit different individuals. Once symptoms are controlled, use PRN. Antidiarrheal preparations like loperamide, avoid codeine phosphate as may cause dependence. Use PRN for patients with diarrhea predominant disease. Use preemptive doses to cover difficult situations, example, air travel. Antidepressants. There is some evidence that low-dose amitriptyline, example 10 milligrams Nocte or SSRIs, may help symptoms. Probiotics. Some evidence of effectiveness. Consider a 4-week trial. Psychotherapy and hypnosis. Evidence of effectiveness but limited availability. Consider for cases that have failed to respond to first-line treatment after 1 year. FODMAPs diet. Some evidence of effectiveness. Refer to a dietitian. Failure to respond to treatment. Consider other diagnosis. Review history and examination plus or minus. Refer for further investigations. Prognosis. More than 50% still have symptoms after 5 years. Okay friends, so we will stop here for today and tomorrow we will start from page number 390. Thank you. Have a good day.